Thanks very much for the kind introduction and for having me here. It's a great honor. So I'm going to talk about something kind of speculative. Could some people with PTSD actually have a different underlying neurodegenerative disorder called chronic traumatic encephalopathy? So CTE has been in the news a lot. It's gotten a lot of attention, which is appropriate. So not much is known about it, unfortunately. Here's what is known. It's linked to repetitive brain injury, typically mild. So it's linked to repetitive concussions. There's some evidence that even a subconcussive injury may be a risk factor for this, but really not much is known. They're just developing animal models for this. It's a neurodegenerative disorder, meaning it progresses. And right now, the only way to diagnose it is at autopsy. You have to look at the brain, and what you see is deposition of the protein tau in neurofibrillary tangles, phospho-tau. Tau is also one of the two proteins that accumulates in Alzheimer's disease. The other protein in Alzheimer's is amyloid. The interesting thing about CTE is that there's typically no amyloid. It's just tau, so it's called a tauopathy. In addition to the absence of amyloid, CTE seems to be associated with a different pattern of tau deposition. In Alzheimer's disease, tau tau accumulates in a very stereotypical pattern, first described by Brock. It sort of moves up from the brainstem, and then it's in the transentorhinal cortex, and it moves to the limbic regions, and then only very late in Alzheimer's disease is it seen in the neocortex. It seems like that may be different in CTE, where the tau deposits seem to appear in the cortex early on, especially around blood vessels. So that's a difference in the regional distribution of tau. My group at NYU, headed by Moni De Leon, we're also looking at a difference in the intracortical distribution of tau, and I'll show you a slide on that later. So like I said, you can only diagnose CTE at autopsy, but there's a lot of interest and effort towards clarifying the clinical features. So I got this from the literature. The group at Boston University is really at the forefront of CTE research. They put together this list of symptoms of CTE, potential symptoms based on descriptions of patients while they were alive correlated with their brains after death showing tau depositions. And it's a pretty big list. This is part of why I'm a neurologist and not a psychiatrist, because there's really a lot of different symptoms there. It makes it very hard to diagnose in life. And so what I did was I just highlighted the proposed CTE signs and symptoms which overlap with PTSD. There's really a lot of overlap. There's also a lot of overlap with depression. And there's really, in general, just a lot of overlap with psychiatric disease. It's impossible to diagnose CTE in life, so it's a combination of psychiatric symptoms. But you can see that a lot of these symptoms are common in PTSD, so impulsivity, depression, suicidality, insomnia, impaired concentration and memory. And I told you this was a little speculative, but in fact, there have been people diagnosed with PTSD in life or depression who, when they died, often after suicide, were found to have CTE, tau deposition in their brain. And so I'm focusing on military veterans. There's been a few military veterans with PTSD who were exposed to, who suffered brain injuries, especially blast trauma. Blast seems especially likely to cause brain damage. But there have been cases of people diagnosed with PTSD in life who were found to actually have CTE. Some of them are very high profile. The Boston University group has looked at, I think, 94 professional football player brains. 90 of them had CTE. Clearly, there's an ascertainment bias because the families donated brains of, loved ones that they were worried about. But still, CTE is probably going to turn out to be common. The problem is, how can we diagnose it in life? So this is what I propose to do to try to diagnose it in life. I'm recruiting patients from the NYU Cohen Veterans Center. It's funded by the Cohen Foundation. It's got two branches. There's a military family clinic for clinical care, and then there's a research side where active and retired military veterans undergo very careful psychiatric, neurologic, neuroimaging, and blood assessment. And it's especially focused on TBI and PTSD and their overlap. So I have, a patient population that I can test for this. And I guess I should have said earlier on, I'm using PET scanning to try to diagnose CTE. PET scanning can show specific molecules in the brain. I'm going to use a new tracer for tau that will show tau in the brain. There have been amyloid tracers for a while. The tau tracers are new. They're not FDA approved yet. So what I'm doing is trying to select patients from this ongoing study of veterans with TBI and PTSD who we think are the most likely to have tau in their brains. So we're looking at people with multiple TBIs. There's no evidence yet that a single concussion has any lasting effects. It seems to be multiple concussions. I'm selecting people with severe psychiatric symptoms, mostly PTSD. There are a few with severe depression too, and a lot with overlap of PTSD and depression. Of the people who were found to have CTE after autopsy, a majority of them complained of chronic headaches. And we have an extensive battery of post-concussive symptoms, including headaches. So I'm selecting people with chronic headaches. And then we also have lots of neuropsychological testing, including motor testing, and including a finger tapping test, which can measure finger dexterity. And before CTE was CTE, it was considered a disease of boxers, and it was called punch-drunk syndrome, and it had some Parkinsonism component to it. And they may be different diseases, but right now we can't tell them apart. But motor impairment was a key feature of CTE, so that's why I'm taking people with clumsy finger tapping. And then, probably the most high-yield group is people who have elevated plasma tau. And so my colleague Sylvia Fossati is measuring plasma tau using this ultrasensitive assay called a SIMOA for single molecule array immunoassay. So until about 5 years ago, it was impossible to measure tau in the blood because the concentration was way too low. With this new device, it's actually possible to measure tau in everybody. So we have values for normal controls and for people with multiple TBI and for people with PTSD and depression. They're all measurable. None are below the level of detection. So, we're going to scan the people with elevated tau in addition to that symptom profile that I showed you before. This is a tau PET scan. It's unfortunately not mine because I haven't done any yet. But this is the tracer I'm going to use. It's THK5351. It was developed in Japan. So this is a healthy control, and there's a little bit of green there, but not too much. This is MCI, meaning mild cognitive impairment, which is sort of a prodrome to Alzheimer's. The red areas and the yellow show areas of increased radiotracer uptake, in this case, the tau tracer. So this shows that there's tau accumulation in the temporal lobes. This is a patient with fairly advanced Alzheimer's disease, and you could see tau accumulation fairly extensively in the temporal lobes. Based on neuropathology, we think that CTE will look different. We don't think it will start in the temporal lobes. We think it will start, higher in the cortex. This is some work I alluded to earlier, done in my lab. we looked at tau and amyloid tracers in patients with and without Alzheimer's disease. And there's a different regional distribution, like I told you before. Tau starts at the bottom of the brain, sort of works its way up, whereas amyloid starts in the top and spreads diffusely around the cortex. But in addition, what we found is that tau tends to be deeper in the cortical ribbon. Tau deposition, which is the green here, is closer to the gray-white junction, whereas the amyloid deposition, which is the red here, is sort of diffused through the cortical ribbon. And these are the overlaps. And this fits with what's seen in histology. And this is a little bit of a feat because, PET does not have the greatest resolution, so normally it would be hard to differentiate the intracortical distribution, but with some, fancy analysis and statistics, we were able to do that. And so I have to end with some questions because I don't have answers for you yet. If I ever get invited back, I will have answers, I promise. The questions are, can tau PET diagnose CTE in life? I really think it can. There's a group, the Mount Sinai group, recently reported one patient, one former football player, who did have tau deposits using PET scanning. But he doesn't have pathological verification. So it's different than in Alzheimer's disease. In Alzheimer's, you can do an amyloid or a tau scan, and these are older people, and eventually, you will get to see their brains and see if the PET scan correlated with neuropathology. Hopefully, you don't get to do that in young people with CTE, so it makes it more difficult. Can tau PET differentiate CTE from Alzheimer's disease based on the regional and the intracortical distribution? It's probably yes, based on pathology, but we need to replicate it using PET. And then do tau blood levels reflect PET-measured brain tau levels? This would be big news because PET scanning is very, very expensive. Blood tests are much simpler and cheaper. So if it turned out that Simoa measured blood tau reflected brain tau, that would be a very useful tool for diagnosing CTE in life. And these are my collaborators and mentors. Moni De Leon and Charlie Marmor are my mentors for this grant. Moni's an imaging expert in Alzheimer's, and Dr. Marmor is a PTSD expert. And then Yili, Waitsui, and Shankar. I've known him for 15 years, but I don't know how to say his last name. He's at Cornell, and he does the PET scanning for us. That's it. Thank you very much.